Welcome students. The topic for today is a little tricky but very important, which has been consistently asked. Myocardial infarction. This is a must know question. Questions have been divided into must know, desirable to know and nice to know. And you also find that it is an essay question. Parts of it can be asked as short notes also. This had always been insisting upon your IQ is equal to your UQ. That is the university question. And in that case, we shall be hitting the nail on the head. A good cartoon that depicts that we are exactly on the point. Ischemic heart disease. The term includes a spectrum of diseases starting from angina pectoris up to sudden cardiac death, in which we find there is an entity called myocardial infarction. But myocardial infarction alone has been highlighted in white because it is a condition where there will be a pathological lesion which can be studied, which can be demonstrated, and which can be photomicrographed and shown. In pathology, always we choose questions and topics which have got pathogenesis or a morphology or sometimes microscopy and complications. Pure clinical questions are out of the purview of pathology as far as the university questions are concerned. Ischemic heart disease was also known as coronary artery disease, but the term ischemic heart disease has stood the test of time. Definition. I always used to say subheadings, and definition is definitely most important. It is an imbalance between the supply and the demand of the heart for oxygen. An imbalance between the supply and the demand of oxygen for the heart, whatever be it. There can be an ischemia whenever there is an increase in demand. This can be because of the increase in the heart rate or the increase in the size of the heart or both. Increase in demand. There is a diminished oxygen supply. This can be because of an anemia or the patient having a congenital cyanotic heart disease, or there is a poisoning with carbon monoxide. Any of these can lead to diminished oxygen supply, leading to a myocardial infarction or other ischemic heart disease. And other things being normal, whenever there is a reduction in the coronary blood flow. And that too, you find that a lot of compromise is required, which can lead to an ischemia. So you find here it is an increase in the demand or a decreased oxygen or a reduced blood flow. Any of these can lead to an ischemic heart disease. Epidemiology, we shall just be passing through it because pages and pages will be given in the text, which cannot be and need not be reproduced. More common in the Western countries, but now India is also catching up with it due to the change in the lifestyle. Increases with age, definitely. More than young children, you find that middle-aged people will be affected by it. Male is to female is 3:1. The females are protected by means of estrogen. The risk factors in ischemic heart disease, this is a mnemonic that I had got, and I would advise you people to kindly learn this. Has lipids. H for heredity, A for age, S for sex, male greater than female, L for lipidemia, I for increased weight, that is obesity, P for pressure, blood pressure or hypertension, I for inactivity, D for diabetes mellitus, and S for smoking. Has lipids, please by heart this mnemonic. The risk factors for ischemic heart disease is going to be part of your answer. Again, a slide that shows a spectrum. It can be asymptomatic, from which the patient can be developing an angina, which can progress on to a myocardial infarction, or it can be just a heart failure. In some cases, you find that there can be a sudden cardiac death. As I told you, we will be sticking on to myocardial infarction, but we should be aware that there is a spectrum of conditions which come under ischemic heart disease. This is a diagram of paramount importance. In fact, very important, do not take it casually. There are three major blood vessels. And this is the left anterior descending artery. This is the left circumflex. And this is the right coronary artery. Remember only these three. Left anterior descending, left circumflex, and the right coronary artery. And the diagrams below, this we people shall draw. And it shows whenever each blood vessel is going to be obstructed, what is going to be the pattern and the distribution of infarct. So here I find that the right coronary artery is obstructed. The infarct is limited to the posterior 1/3 of the interventricular septum and the posterior wall of both the ventricles. Posterior 1/3 and the posterior wall of the ventricles. If it is going to be a anterior descending artery, which is the main artery, there can be the anterior 2/3 of the interventricular septum and the anterior wall of the left ventricle. And if it is going to be the circumflex artery, you find that the circumferential area, that is the left lateral border, can be affected. Again, I repeat, because it is of great importance. Three blood vessels, left anterior descending, left circumflex, and then there is a right coronary artery. When the right coronary artery is obstructed, posterior 1/3 of the septum, posterior walls of the left and right ventricle. And left anterior descending, anterior 2/3 of the interventricular septum and the anterior wall. And in the case of a circumflex, left circumflex, you find that the left lateral border of the ventricle is affected. So again, the main things are mentioned over here. Please do remember this and draw this picture alone. Of these, the most important will be the left anterior descending artery. The obstruction can lead to more than 50% of the infarcts. The right coronary artery, it is going to be about 35% of the myocardial infarcts. Circumflex for about 15%. All the other branches you find will be only about 1%. And if it is going to be intramyocardial branches, there is no infarct as such. So please remember these three data. Pathogenesis. So always I used to say subheadings. The subheadings will take you to the answer. Pathogenesis is one. Now what is the basic cause of this myocardial infarction? More than 75% of the cases are due to coronary atherosclerosis. Coronary atherosclerosis by itself, sometimes it can be because of a complication of atherosclerosis. The complication of atherosclerosis we shall again be seeing. Next is platelet aggregation. The platelet aggregation is promoted by means of thrombexin A2 and it is prevented by means of aspirin. It is a drug of choice in cardiology. And omega-3 fatty acid has a protective effect. So platelet aggregation is the second pathogenetic mechanism. Third one, you find whenever we do an autopsy, there is no obstruction at all. but still the patient has died because of myocardial infarction, and that can be because of coronary vasospasm. Spasm is there is a rigidity in the blood vessel, it doesn't allow the blood to flow. It happens in cocaine poisoning. Embolism. So atherosclerosis can lead to an embolism on its own or embolism from elsewhere also. The emboli can lead to an obstruction of the coronary artery. And the last condition can be hemodynamic alteration. If a patient is going to be having a low blood pressure, you find that there will be lesser amount of blood going into the coronary arteries, leading to an ischemia. So this is an atheromatous plaque, and then there is a rupture of the plaque. There can be a thrombus formation, and there can be a vasospasm. These are the mechanisms, please remember, and the MCQ will be most common cause will be coronary atherosclerosis. This we had already seen in the chapters on atherosclerosis. What can be the complications? There can be a rupture over here. It can undergo healing. There can be embolism as is denoted in this diagram. There can be a superimposed thrombosis. Try to recollect this one. Again, a picture of an atheromatous plaque. So this is a plaque, lipid crystals, etc. are there. But that is not the purpose of me showing this picture. What happens? Let us recollect. These are all the various things that we should remember. There is a thrombus formation, embolism can be there, ulceration is one of the complications, calcification, and look at this place, you find that there are canals. We call it recanalization. Sometimes there can be organization. This is more of an answer for an atherosclerosis or a thrombosis. Please do remember, one question leads on to the other. A very important point, morphology. What is the morphology of a myocardial infarction? So this is a question, and please remember these types. There are 4 different types of it. 2 are most important. One is called a transmural infarct. Transmural means it involves the entire thickness of the heart wall, not valve. Entire thickness of the heart wall. And in some cases, it is limited to the subendocardial region. We call it a subendocardial infarct. 2 things. The infarct at a distance is a little more complicated term, but let me explain. In some patients, when the obstruction is going to be gradual, there will be a circumflex artery that develops. A circumflex artery, it is some kind of a bypass that develops. So, whenever there is going to be an obstruction of the main vessel, nothing happens. But when there is going to be an obstruction of a circumflex, there is an infarct. It will occur at a different place, and hence it is called infarct at a distance. Stuttering infarct is another one. You find that there can be various ages of the infarct. An immediate infarct, a late development, and even a fibrosis. All these different stages can be seen in the same infarct, which is called stuttering. 4 different types, please remember: transmural infarct, subendocardial infarct, infarct at a distance, stuttering infarct. These things we must answer because it is an essay question. Morphology is one of the most important things that is expected. And most of the changes that we are going to see subsequently is because of the dead myocardium from which lactic acid is being released, which leads to the damage, lactic acidosis. So the types that I had mentioned, again I am showing you, you find that it is involving the entire thickness, called as a transmural infarct. Limited to one region, I call it as regional. Subendocardium, this is a lumen, endocardium. Beneath that, there is an area of infarct. We call it a subendocardial infarct. It is regional in one place. Sometimes the entire ventricle is surrounded by a subendocardial infarct, which is called circumferential. In some patients, you find that diffuse multifocal infarcts can happen. There are different causes. Imagine what will happen to a patient who is having repeated emboli, showers of emboli. This patient can be having multiple infarcts. I hope this diagram is quite simple. You can draw, shall draw, and will draw. Factors that affect the development of an infarct. Usually you find general pathology and systemic pathology are not separate. There is a topic called as infarction in general pathology and circulatory disturbances, in which it has been mentioned. The development of an infarct will be based on the rate of development of an occlusion. It has to be fast. Depending upon the collateral blood flow, if there is no collateral, there is a definite infarct. Demands of the myocardium, actively pumping, and then patient is having a hypertension, he goes in for infarct. Oxygen carrying capacity of the blood. Patient is severely anemic, then he is prone for an infarction. Rate of development of the occlusion, the collateral blood flow, then the demands of the myocardium in size or function, oxygen carrying capacity of the blood. These are the factors that affect the development of an infarct. TTC, triphenyl tetrasodium chloride. Here it is an autopsy specimen of the heart. The heart itself, you find the ventricle is very much thickened, and what they have done is within the first few minutes you will not be able to, or even hours, you will not be able to identify. So they paint it with a substance called as triphenyl tetrasodium chloride, in which the live myocardium will take the red color and the infarcted area takes up a pale color. This is one method of diagnosing, and this picture also, it is showing a mammoth hypertrophy of the ventricle and a reduced lumen. Changes in the myocardial cells, and I have denoted it. You will have to buy heart. You will have to buy heart this. So there are the various changes. Within the first few hours, there are no changes. And after some time, you find that there is a coagulative necrosis developing, not very significant grossly. And it takes more than 24 hours for the gross changes to be obvious. But microscopically, you can see coagulative necrosis. There can be neutrophils. Subsequently, you find that the area of infarct becomes softened and yellow. Coagulative necrosis is becoming more liquefied. And you find that the inflammation is replaced by macrophages. There is a hyperemia of the border. Hyperemia means congestion in the weeks, and it is replaced by granulation tissue. Finally, there is a scar by collagen. Microscopy, once again I will say, there is a coagulative necrosis, neutrophilic infiltration, replaced by macrophages, finally a healing and a granulation tissue, then scarring by collagen. Please remember this you will have to write. What are all the changes that happen in the myocardium, which is shown in these pictures, courtesy illustrated pathology. So here you find the various changes. Initially you find that this looks almost like a normal myocardium. There is no change, and there is no change in the ventricular wall also. Later on you find it becomes pale, mottled, and you find that there is a separation of the fibers. The myocardial fibers become separated. And this is what we had said earlier, there is an infiltration by the neutrophils. Edema is there, this is a normal fiber, and look at these fibers. They are losing all the details. No striation, no nuclei. but the outline is preserved. Exact description of a coagulative necrosis. And the area becomes paler grossly. And neutrophils are still over there, and then blood vessels keep coming in, a granulation tissue that is being formed. Finally, you find that it is replaced by a fibroblastic tissue or collagen. And this is what we said as congestion. You find that the peripheral area is pale because of the proliferating capillaries, and this is called congestion. A border of redness can be seen in the necrosis. And finally, there is a pale fibrous tissue that is replacing. And look at this one, hardly any myocardial fiber, but bands of collagen in the area of infarct. So these things you people will see. I would advise you people to kindly repeat it any number of times, which is useful. This flow chart is also very good, and I would like you students to kindly write it. It is not my original work. It is one Dominique Anile, and this person is a French pathologist. There is a myocardial infarction, impaired contractility can be there. There can be a tissue necrosis. There can be arrhythmias which can develop because of the electrical instability. Finally, there is inflammation leading to a pericarditis. In all these conditions, there can be a cardiogenic shock, there can be a stroke that is developing, and there can be the complications in the cardiac muscle, resulting in a cardiac tamponade. These things will be shown again, but please do remember, because it is easier for us to draw a flow chart or write a flow chart. Impaired mobility, and then there is a tissue necrosis, electrical instability, and pericardial inflammation. Now, what are the complications that we mentioned? You find that sometimes you find there is a ECG wave, suddenly it tapers off, there is a sudden cardiac death. Sudden death is one of the complications. Sometimes it becomes highly irregular, what we call as arrhythmias. It can be a ventricular arrhythmia. So this is one. This is an area of infarction that we are seeing, leading to these changes. Sometimes clinically there can be a severe pain alone, which is seen in angina pectoris. A typical condition will be a stabbing pain in the chest, which can be radiating to the left shoulder or sometimes to the epigastrium also. My professor of medicine used to say, many an eminent cardiologist has treated himself with antacids to be found dead the next morning because the pain was found in the epigastrium. So that can happen. Cardiac failure is there. Once the muscle is diseased, it cannot contract, there is a failure. Then there is an infarct, which we showed in the earlier pictures. There can be a superadded thrombosis, which may be there. And finally, there can be any insufficiency of the valves. These pictures, please do remember, you can see them again. And a diseased myocardium can undergo a dilatation, which is an aneurysm. And then the types of infarct, a transmural infarct can be there, and there can be a pericarditis. Look at this fibrillary area around, which is a pericarditis. Sometimes it can be just immunological, called as Dresler's syndrome. Rupture of the myocardium, and you find it is filled with blood, called as cardiac tamponade. And there can be a rupture of the interventricular septum, rupture of the papillary muscles. So another diagram which I would like you to remember, go through this picture very slowly when you are free. The various complications I have mentioned again. There is a heart failure, there is a Dresler's syndrome that is marked over here, rupture of the papillary muscles, which is shown in this condition. There is a thrombus, which is over here, a thrombus is being formed. Cardiac tamponade, when there is a rupture of the wall, it goes into the pericardium. Arrhythmias, look at this yellow line, you find that the bundle of His, etc., and the fibers are being upset and you get an arrhythmia. Pericarditis, when there is an inflammation, recurrence, of course, there can be recurrent myocardial infarctions, aneurysm, the dilatation that we are seeing over here. Please do remember a nice picture for you to review at the last minute. So the precaution is read carefully. If you still have got some doubts, you reproduce this one. This is a mnemonic from the net, Darth Vader. Death is one complication, arrhythmia, rupture of the various structures, tamponade. Heart failure can be there, and valvular disease, aneurysm of the ventricles, Drexler's syndrome, embolism. And when I say rupture, it can be the papillary muscle or the interventricular septum or the myocardium itself. So this particular one, it is quite popular. Please do memorize it. These are the various complications of myocardial infarction. And this is just for you people, identify the lesion. Identify the, I'm not going to tell you anything, you people identify the lesion. I think we are coming to the end of this session. Efkaristo. And probably it is denoting us, what am I trying to tell you people? Maybe this is how we will be appearing at the time of exam. Thank you, one and all.